Okay. So today I'll be talking about the perioperative management of pheochromocytoma. So there is the important aspects are preoperative, intraoperative, and postoperative management. And there are some special circumstances which we'll be talking about. So just briefly, the WHO definition of pheochromocytoma paraganglioma is any tumor arising from catecholamine producing chromaffin cells in the adrenal gland, as well as closely related such catecholamine secreting tumors of extra-adrenal sympathetic and parasympathetic paraganglia. So most extra-adrenal pheos secrete, just to revise, most extra-adrenal pheos secrete epinephrine and of course norepinephrine, and adrenal pheos, which are extra-adrenal called as paragangliomas, pheos from the adrenal secrete epinephrine and norepinephrine, and these patients usually have episodic hypertension. Unlike the norepinephrine, usually they have sustained elevated hypertension. So adrenal pheos can have sometimes normal blood pressure, sometimes elevated blood pressure. And pure epinephrine secretion can actually cause hypotension. We'll see in the coming slides why that can be a possibility. And there could be rarely non-functional silent pheos, which probably are still growing, and maybe they do not secrete the hormones that are active, that are actually going to act on the receptors. In addition, pheos can produce other substances which may not be relevant clinically. So there are adrenergic receptors which are alpha 1, alpha 2, beta 1, and beta 2. This is important to understand because how each metanephrine or epinephrine or norepinephrine is going to act on the blood vessels, and how the drugs that we are going to use, that is alpha blockade and beta blockade, are going to have effects on the patient. So in order to understand that. So alpha 1 receptors cause both arterial and venous vasoconstriction. The catecholamines that act on these are norepinephrine. This is important for us. And alpha-2 mediated inhibition of presynaptic norepinephrine release, and thus causing vasoconstriction caused by both norepinephrine and epinephrine. Beta-1 stimulation causes heart stimulation in terms of chronotropy, inotropy, and beta-2 stimulation causes vasodilation. So this point is very important because we are not supposed to block beta receptors before blocking alpha receptors. So alpha 1 and beta 2 have exclusively norepinephrine and epinephrine acting, and alpha 2 and beta 1 have both of these acting through them. So catecholamines, the final targets of catecholamines are these receptors, and they have overlapping and different effects on each, as I have just mentioned. So epinephrine is more potent on beta 2 receptors of skeletal muscle vasculature that can actually cause hypotension. That is what I was just talking about. And more potent alpha adrenoreceptor agonist. It is a more potent agonist than norepinephrine. And the norepinephrine is more potent beta 1 agonist in the heart. So that can actually cause reflex alpha 1 mediated vasoconstriction within the vasculature. So this slide actually just says that there is so much hormone within these tumors. I'm not going to the specific numbers, but there's so much of hormone per gram of the tumor tissue that there are 1,000 ampules of norepinephrine within an average adult, that is 4 centimeter pheochromocytoma. But the actual symptoms are not such catastrophic. Of course, it can go to catastrophe sometimes, but there is something called as desensitization because of prolonged exposure to varying amounts of these catecholamines. The receptors actually undergo desensitization. That's why there is not so much of symptoms many a times. But this is important to understand that a potential stimulus to the tumors can actually release so much hormone into the body and can cause abnormally high BPs, more than 200, and can cause strokes and such catastrophic events. This desensitization happens because of internalization of receptors and decreased binding affinity of catechol to these receptors. So this explains that each patient can have varying symptoms and variable amount of blockers that are needed despite having similar biochemical results. So prolonged exposure to these catecholamines results in constriction of both arterioles and venous segments, because which cause contracted blood volume. So there is volume contraction. This is very, very important point in case of Pheo and paraganglioma. So, and this is one thing is volume contraction. The other thing is effect of persistent untreated hypertension. So hypertension as such, we all know that has effect on the cardiopulmonary system. So it can cause left ventricular failure, it can cause angina, it can cause dilated cardiomyopathy, there could be heart failure, pulmonary edema, hypertensive crisis, arrhythmias, and ischemia. So because of all this, there is no doubt that definitely these tumors have to be removed, irrespective of whatever size and whatever value of the meta and non-metanephrine is. But as we are just seeing, it is such a high risk tumor, and we need to prepare these patients properly for successful outcomes. So the goals of the preoperative management, number one is, of course, the optimal control of BP. And the second thing is to control the other symptoms that are related to Pheo. And the third thing is prevention of perioperative complications. So the mortality has reduced much, much more because of availability of drugs. And it is important that whether or not hypertensive crisis, hypertension or hypotension episodes occur perioperatively, it has been seen that preparation of the patients with appropriate medications before surgery has shown to improve the mortality. It used to be very, very high a few decades back, and now it is less than 1%, thanks to all the drugs that are available and thanks to the understanding that we have of the pathophysiology. So a positive correlation exists between the complication rate and the size of the tumor, the duration of operation, and of course the levels of catecholamines. The nature and severity of hypertension and its complications have to be documented, and this is very important because we have to take an informed consent. Though the mortality has reduced to less than 1%, it is still a high risk surgery. ECG is a must in all patients, and it has to be repeated before surgery as well. And echo has to be done. And suppose if patient have had angina in the past, then they have to be reevaluated, and maybe if needed some kind of course we all take clearances before surgery from cardiologists, and glucose has to be measured, and the kidney function, and of course we'll do chest x-ray. We all understand the importance of hematocrit because of volume contraction, and whenever we start expanding the volume with the drugs, the hematocrit falls. And it is also important that one should keep in mind the multiplicity of the Pheos or paragangliomas that are possible, bilaterality, and associated syndromic features. So we also have to assess the end organ damage, which include the effects because of hypertension, like the eyes, kidneys, and heart, of course, and other organs. So we have to try to normalize the BP, normalize the heart rate, and optimize the function of other organs. If there is, because of volume contraction, in my experience, we have seen some patients who have pre-renal azotemia. These have to be controlled with volume expansion, restore volume depletion, prevent surgery-induced catecholamine storm, that is, of course, which we, by blocking these receptors, and prevent serious consequences during and after surgery by preventing abnormally high heart rates and arrhythmias by beta blockade. So there are several studies which have looked at whether to block these receptors or not. And there are actually innumerable studies. There are no randomized controlled trials though. And whether, time to time, many studies have come, but I will just tell you the gist. So the conclusion is that the blockade is not going to prevent hypertensive surges during the surgery, but crisis and other complications like catastrophic events have definitely improved because of preoperative blockade. That's what many studies have shown. So if we just look at the minimum, maximum, and there are studies supporting and not supporting both, but it is, according to the current recommendations, it is recommended to block the patients of Pheo and paraganglioma, and with alpha blockade followed by beta blockade. So I have been to SN in Germany, Professor Martin Walls, who is the pioneer in retroperitoneoscopic adrenalectomy. They do quite a few Pheos every month, and they don't block the patient beforehand. But there are few groups which support not blocking, but the consensus and the recommendations have been to block these patients. So alpha blockers, beta blockers, calcium channel blockers, and other antihypertensive medications are all available, but the standard is to use alpha blockers followed by beta blockers, and we add calcium channel blockers if the hypertension is not being controlled by only alpha blockade. So it's very important. Beta blockers should not be used before using alpha blockers, and sometimes we have drugs like arcamine also have been used. So alpha blockers are of two categories. One is non-selective and the other is selective. Non-selective phenoxybenzamine is the drug that is in clinical use. The availability is an issue, but it is available with a little effort, and it's slightly costlier than prazosin, but it is there are some advantages as I'm going to enumerate in the coming slides. Selective alpha-1 blockers are mainly prazosin, doxazosin. Terazosin and urapidil are not routinely used. Even doxazosin is also not routinely used, except that I have just seen in patients who come from the South African countries where they use doxazosin instead of prazosin. So, ideally, ideally the blockade, how long it has to happen and when we should start is a point of debate, but it is seen that at least a week of blockade is necessary before taking the patient to surgery, but ideal is to have at least 2 weeks. So it has to begin gradually. We can't just start at the maximum dose. We have to start with the minimum dose and then keep escalating the dose, looking for the side effects that these drugs can have. So phenoxybenzamine has been the mainstay of the drug that has been used for many years, and the half-life is about 24 hours. So this gives us the chance to administer it twice a day. But we can use it thrice a day also, but the twice a day dose also works. So this acts by non-competitive covalent binding, irreversibly blocks the receptors due to alkylation, and because of this nature of the action, it is needed that the new receptors are synthesized for the body to recover from the action of this drug. The starting dose is about 10 milligrams BD or thrice a day, increased up to 1 milligram per kg. That means average 60 kilo adult will need about 60 milligrams, that is 20 milligrams thrice a day, or that is how it is used. 40 milligrams twice I think are not used. So 20 to around 20 to 60 milligrams is what one can use. So like with other alpha blockades, this also this starts causing volume expansion. So in order to retain the volume into the intravenous compartment, we need to give salt also. So a high salt intake, of course, we should start this also gradually, because otherwise already patient is hypertensive, and as soon as you start, you should not start 15 grams per day. Up to 15 grams is can be given, but 5 to 10 grams is sufficient. We usually give by putting salt in the capsules because patients may not be able to take so much salt. IV saline is used by some endocrinologists. Here our endocrinologists recommend to use IV saline, but I keep insisting that oral fluids also work well because these patients are ambulant and they're able to drink. But our endocrinologists prefer to give IV saline to increase the introp volume, especially if the time is less. So the advantage of phenoxybenzamine is that it has prolonged duration of action. So twice a day dosing, non-competitive blockade, and prevents surges of catecholamine release in preoperative phase. So there is significant, of course, reduction in operative mortality. But the disadvantages are that because of the alpha-2 blockade, there is a presynaptic release and cause reflex tachycardia and excessive orthostatic hypotension. And it can cause sedation, significant sedation, and you see that the patients are drowsy in the first couple of days after the surgery. So it can cause nasal congestion, and patients can have dizziness especially because of orthostatic hypotension. And systemic arterioles are insensitive to alpha agonists. So in post-op, if we excess volume can actually go into the interstitial fluid, because the drug is still within the body. So, and the drug is quite expensive compared to prazosin, but it is affordable. So prazosin is a selective alpha-1 antagonist, and they don't block the presynaptic alpha receptor, so don't enhance the tachycardia mediated by the norepinephrine presynaptic release. These are short acting. The duration of action is about 2 to 5 hours. So we can actually adjust the dose rapidly, but of course, more frequent dosing is needed. They have high first pass metabolism. That means loading dose. I mean, of course, that means it's going to take some time for the effect to become consistent. So hypotensive effect is concentration dependent, and there could be profound first dose hypertension. So we typically tell the patient that you start taking in the bedtime, and we start with 0.5 to 1 milligrams first on the day 1, and then the day 2 we give in the morning as well as in the night, and then gradually increase. We can go actually up to 14 milligrams, but that yeah. So and if the BP is not controlled adequately with prazosin, we can actually add calcium channel blockers. Phenoxybenzamine should be avoided on the day of surgery. In fact, some people avoid it in the night before a surgery also, if we are going to take it early in the morning, because that can actually cause prolonged hypotension post-operatively. But prazosin has to be given because its half-life is short. And because of this, the post-op hypertension is less. So doxazosin is also similar to prazosin, but I don't have experience using this. It's also a good alternative. It's an alpha-1 antagonist, has high oral bioavailability, and it causes only moderate amount of postural hypotension. So dosing is easy. Maybe but the advantage is it has long duration of action. So OD dosing is possible. So there are many other alpha-1 blockers and effects, but the most studied are these 3. So coming to beta blockers. So beta blockers help in controlling the heart rate, because the heart rate can go up to 120, 140 if there is volume constriction and we are only going to do alpha blockade. So it's important that we also decrease the heart rate. And we generally use metoprolol, propranolol. I mean, metoprolol is the most commonly used drug, but we have IV preparations also, and we actually, I think metoprolol is the safest and has been used for a long time. And some have tried using labetalol, which is combined alpha and beta blockers, which has predominantly beta action, but metoprolol 25 to 50 milligrams up to TDS we can go. And this also has to be gradually added depending on the heart rate. So of course, calcium channel blockers, we have many of them. So amlodipine, nicardipine, and these 2 are the most commonly used. And we have good experience with amlodipine, as we all know that it can accentuate the control of blood pressure. And it is a safe drug which doesn't interfere and doesn't exaggerate the production of or release of the hormones. So other drugs, I don't have the experience of using them, nor I've not seen them being used also. But arcamine, I have seen our endocrinologists used to add in SGPGI, but I don't have personal experience using these drugs. But yes, these are the other options to control if BP is not being controlled. And volume therapy, patient has to take high amounts of water and salt to increase the volume, intravascular volume. And this actually can cause low hematocrit, and that should be corrected. So preoperative blood transfusion, if it is very less, otherwise we have to keep the blood ready for intra-op and post-op. So even though patients are normotensive, still they have to be blocked. Of course, we are not going to block them aggressively, but it is important that they are also blocked, because there's a possibility that they may have surges during surgery. And there have been some studies which have seen whether it is better by having the patient in the hospital or doing this blockade as an outpatient. It has been seen that there is a better outcome if we do it in patient, because we have more control on how the patient is being prepared. And we can actually monitor the dosing, the heart rate, and if there are any arrhythmias, if there are any, and we actually get to understand the profile of the blood pressure and heart rate of the patient over about a week. Even in corporate hospitals, we admit the patient at least for 5 days to have a good idea of their hemodynamics. So we all are familiar with the Roisen's criteria, which have given the safety. I mean, if we reach these criteria, it is safe to take up the patient for surgery, whether it is within a week or, I mean, at a week or after 2 weeks. So no in-hospital blood pressure should be more than 160/90 for at least 24 hours before the surgery, and no orthostatic hypotension not less than 80 or 80/45, and no more than one extra systole in 5 minutes, and no ST changes or T wave inversion which are suggestive of angina in the ECG. So these are the Roisen's criteria, which according to the anesthetist is a safe time when patient can be taken up for surgery. So these are up regarding the blood pressure and the cardiac related management. Other things are, if the Pheo is large and if it is towards the left side, it is possible sometimes that there could be injury to the splenic vessels, or we may have to remove the spleen. In that case, just as a prophylactic measure, of course, we are going to take all the measures to not injure the spleen or its vessels, but it's recommended to gives vaccination against the capsulated organisms like pneumococcus and Haemophilus influenza. And there should not be any strenuous physical activity before surgery, and smoking and alcohol completely no. And the patient, of course, has to be admitted as I would say a week before or 5 days before. And patient is instructed to stay in the bed. And if there is any if suppose they're going to get up and they start feeling dizzy, then they can hold to the rails. And these are all important just to have in-hospital safety. If it is phenoxybenzamine, no morning dose. If it is prazosin, morning dose can be given. And if bilateral adrenalectomy is planned for bilateral Pheos, then of course the steroid adrenocortical hormones, hydrocortisone coverage is mandatory. And there's no, the sedation diazepam can be given, and so it's always better to avoid atropine premedication in these patients because it can cause tachycardia. So avoid all the drugs that can cause during the hospital stay that can cause catecholamine release, that like the foods like cheese, bananas, wine, soy sauce, smoked and aged meat and fish, and the drugs like glucagon, steroid, histamine, angiotensin 2, and vasopressin. And nasal decongestants can sometimes contain drugs that can cause interference with the drugs that we are using for alpha blockade. So, and MAO inhibitors should also be avoided because they can cause high levels of circulating catecholamines. Antibiotics like linezolid can also have similar effect like MAO inhibitors. And drugs like dopamine receptor antagonists have to be avoided. We remember the story, all those who have done from SGPJ, that there was a lady who was given metoclopramide and had a severe episode of hypertensive crisis in endocrinology ward at SGPJ, maybe in the early 2000s. We all must have heard that story. So intraoperatively, the danger timings are 3. Number 1 is during intubation, the other is during tumor manipulation, the third is during just after the tumor, the adrenal vein ligation. So safe anesthesia protocol, there should be a large bore, there should be large bore IB lines, a central line, arterial catheter, ECG monitoring, urinary catheter, of course, and pulmonary artery catheter is not generally used, though it is mentioned. And so patient should be handled without any rush and no undue straining. So there are some drugs that are safe, some are not safe. And during induction, it's better that all the reflexes are toned down by using lignocaine IV during laryngoscopy, and the patient can be first paralyzed by using isoflurane, and avoid excessive stimulation of the muscle contraction. I mean, the drugs that cause muscle contraction during relaxation, like succinylcholine. And so isoflurane is preferred, and desflurane actually, though is cardiac safe, it's not to be used because it can precipitate non-neurogenic catecholamine release. And so atracurium, vecuronium are the most common relaxants that are used. Succinylcholine is better avoided. So maintain the CVP at 8 to 10, and these are all important. Actually, these are standard for any patient with high risk of cardiac and hypertensive disease. And the end tidal volume PCO2 at about 38 millimeter mercury. And of course, epidural catheter can actually decrease the postoperative pain. But if it is laparoscopic, I think we can do away with this. And so intraoperative hemodynamics. So there are some definitions which are given. What are hypertensive episodes? Each time the blood pressure, the systolic blood pressure is more than 30% above the pre-induction baseline, and severe episodes when the systolic is more than 200, and hypotension if the systolic is less than 90, tachycardia if it is more than 110, bradycardia if it's less than 50. I mean, we all take these things into from the monitor, what was the highest BP, what was the lowest BP, and what was the heart rate. And sustained hypertension is if the systolic BP is more than 180 for more than 10 consecutive minutes. And sustained hypotension is less than 80 for more than 10 consecutive minutes. And these need treatment with drugs intraoperatively. So this is what anesthetists use to start actually treatment during the operation. So sustained tachycardia is pulse rate more than heart rate more than 120 for 5 minutes, and hypertensive crisis if BP is more than 180 over 110. And significant symptoms and more than 220 if there is a, or 140 can actually be called a hypertensive emergency. So there are various drugs that are used in hypertensive crisis, like the SNP, the glyceryl trinitrate, and verapamil, nicardipine. Most commonly used are GTN and SNP, sodium nitroprusside and glyceryl trinitrate. So the sodium nitroprusside is used with that are light. I mean, we cover the bottles with black color covers, the tubings also, because this is photosensitive. And glyceryl trinitrate is other drug to which can, these are IV drugs which can immediately lessen the blood pressures. So of course, we have noradrenaline infusions to tackle the hypotension. And the immediate post-op, actually, patient should be ideally should be fully awake and breathing spontaneously at the end of the operation. And in the recovery room, we have to monitor the urine output, the heart rate, blood pressure, and of course the heart rhythm, central venous pressure, and the level of consciousness, because the phenoxybenzimine can cause sedation. So the three important complications that we have to watch for are hypertension, hypotension, and hypoglycemia. So post-op hypertension is managed with high amounts of fluids. We can go up to 125 milliliters per hour. And it is best monitored through urine output, actually. And it has to be titrated as and when the BP starts improving. And it's going to take a while for the volume to build up, and then the kidneys and everything starts improving. So at least for maybe half a day to 1 day, patients may need high volumes of fluids. And so we can use NORAD infusions to maintain the blood pressure if in case of hypotension. That is the most common drug used. And post-op hypertension, some patients may have, because of the long, depends on the duration of hypertension that they've been having. Some patients can still have hypertension post-operatively. They may take up to 6 months for the BP to normalize. So it is important that they continue to get antihypertensives if the BP is on the higher side. So we can actually use calcium channel blockers, and if not, we can start over with the alpha blockers also to control the BP if in the post-operative period. So hypoglycemia, because of the persistent stimulation because of Pheochromocytoma, there would have been hyperglycemia. And as soon as this is taken out, there's possibility of reflex hypoglycemia because of the alpha receptors, and patient has to be monitored for hypoglycemia. So the other thing of contention is when to do the repeat metanephrine or metanephrine testing. It's ideal to do it after about 6 weeks post 1 month to 6 weeks post op, but it is okay that if we do it within a week after surgery also, especially when in our settings where the patients come from very far off places, and that we may not get a chance to measure them sooner. So suppose if it is not come down, then we can repeat the test about 4 to 6 weeks post-op, and it hopefully normalizes by then. And then the repeat measurements should be done every yearly after that for at least 5 years if asymptomatic. So pregnancy is a special situation where it can compromise both the mother's and the fetus's health, and it can cause uteroplacental insufficiency and IUGR, fetal hypoxia, and of course death is also possible. And phenoxybenzamine is safe, and prazosin is also safe during pregnancy. And actually, there are some drugs like propranolol which can precipitate premature labor, and it has to be judiciously managed with alpha blockade, and of course, if needed, we have to start beta blockers if the heart rate increases. And it is safe to perform surgery in the second trimester and during the cesarean section. So, but the patient has to be monitored for continuously for more frequent monitoring than the regular patient with Pheo or the regular pregnant lady. Children also, the management remains the same, and children, if they're having Pheo, the syndromes that can involve having Pheo and PGL have to be ruled out and should be evaluated for further features. So just to conclude, this is just like a revision to conclude. Pheo has been having high perioperative mortality rates in the past, but because of the perioperative management, it has become less. And so even though there is limited evidence that blockade is going to cause less hypertensive crisis in the intraoperatively, it is ideal to use it because we don't want to land up in catastrophic situations. Thank you.